applied anatomy of eyelid and the face cue scoring system. Change नहीं हो रहा. Now eyelid, it's a complex specialized facial adaptation which functions as to protect, moisten and clean the ocular surface, and it is intricately connected to the facial anatomy, the lacrimal system and the orbit. A brief talk about the topography. The eyelids cover the upper and lower parts of the eyeball, and the vertical palpebral fissure height is about 10 to 11 millimeter, and the horizontal palpebral fissure height from the medial to the lateral canthus is about 28 to 30 millimeter. The lateral canthus lies at a level of 2 to 4 millimeter above the medial canthus, and the vertical lid crease in the upper eyelid is about 8 to 11 millimeters. Now, few abnormalities of topography. Blepharotosis is if the vertical lid height or the margin reflex distance is decreased, and the upper eyelid, there is drooping of the upper eyelid. Blepharophimosis is a condition where there is shortening of the horizontal palpebral fissure. If there is increase of the horizontal palpebral fissure with increase in the pars lacrimalis and the pars ciliaris, and there is lateral ectropenia in the upper and lower eyelid, it is known as euryblepharon. Whereas if there is an increased lid fold in the lower eyelid, it is known as epiblepharon. Now, as we can see that the upper and the lower eyelids are similar in anatomy, and from anterior to posterior the structures are skin, subcutaneous fat tissue, then a layer of striated muscle, that is the orbicularis, then the layer of levator, then tarsus, orbital septum, Mueller's muscle and conjunctiva. Eyelid skin, it extends from below the eyebrow superiorly to the cheek. It is the thinnest skin in the body, and it is highly stretchable, and also it has very thin subcutaneous tissue. So it has faster healing and minimal scarring, but since it is highly stretchable, eyelid edema can stretch it up to 3 times, and also there might be permanent stretch leading to blepharochalasis and dermatochalasis. And most importantly, skin, this type of skin is not found in anywhere in the body, and there is difficulty in skin grafting. We can try medial arm skin or the supraclavicular skin, but like for like match is difficult. Now, eyelid margin, it can be divided into the pars lacrimalis, which is medial to the punctum, and pars palpebralis, which is lateral to the punctum. Pars lacrimalis is rounded margin, and pars palpebralis is square-edged margin. The specialized structure in the eyelid margin is the eyelashes, which are specialized hair follicles. The eyelashes point up and out in the upper lid and down and out in the lower lids. They are highly innervated and sensitive, and the follicles of the eyelashes are 1.4 to 2.4 millimeter deep, and we should keep this in mind while performing electrolysis. There might be lash ptosis, which indicates a suboptimal orbicularis and rhyolin muscle support, and the condition known as cilia incarnata is the lash growth from above the eyelid margin. Here we can see a cilia crescere internum. There might be also an externum variant. The other structures of the eyelid margin from anterior to posterior are the anterior eyelid margin, then the gray line, which is formed by the insertion of the rhyolin muscles, then the meibomian gland orifices, the mucocutaneous junction, the marginal conjunctiva, and the posterior eyelid margin. The marginal conjunctiva extends up to the epitarsal border. Now, the orbicularis, it is the chief striated muscle of the eyelids. It is part of the superficial muscular plane, and it is connected to the eyelid skin by fibrous septa. It originates from the nasal part of the frontal, the maxilla in front of the lacrimal crest, and the anterior surface and borders of the medial palpebral ligament. It has various parts, and the orbital portion is supplied by the temporal branch of the facial nerve, and the zygomatic branch of the facial nerve supplies the palpebral part, the preseptal and the pretarsal. Here we can see that the different parts, already I have mentioned. The pretarsal part is further subdivided into superficial and deep. The deep is also known as the Horner-Duvernay muscle. And the other specialized modifications, the pars ciliaris as the muscle of rhyolin, the pars subtalaris, that the Claude's muscle, and the pars fascicularis, the Lifham's muscle. This is responsible for the direction of the eyelashes. I'll not go into details of the individual parts because I'm running out of time. Now, here is a diagram of the preseptal head of the orbicularis oculi, the superficial and the deep head, which is originating from the medial canthal ligament, and they are the canaliculi are included within the of the preseptal fibers. The orbital part, it originates from the frontal process of the maxilla, and fibers pass around the orbital rim in a concentric fashion, and without any delay, it inserts just inferior to the origin after concentric arrangement around the eyelid margin. So orbicularis is actually a sphincter muscle. It has dual blood supply from both the external carotid and the internal carotid system. And the functions are involuntary blinking, which is caused by the preseptal and the pretarsal components, and forced closure by the orbital and the preseptal components, and lacrimal pump by the Horner's muscle, which is the deep component of the preseptal fibers, and lipid pump, that is from the meibomian gland orifices, is by the pretarsal and most commonly the Rylan muscles. Now, medial canthal ligament, it is one of the structures of the eyelid skeleton which connects the tarsus to the bone, and it is anteriorly attached to the anterior lacrimal crest and superiorly along the frontal process of maxilla and the frontal bone. The deep part, which is important, passes along the lacrimal fascia to insert on the posterior lacrimal crest. Here is a diagram of the same of the medial canthal ligament, the tarsus and the lateral canthal ligament, which forms the eyelid skeleton. And the lateral canthal ligament is the fibrous lateral tarsal terminations. It has two crura and it inserts at the Whitnell's lateral tubercle. It is also connected to the lateral rectus check ligament and is attached to the orbital septum, the lateral horn of the levator, the lacrimal gland fascia, and the Lockwood's ligament. Here's a clinical implication is that in case, since the lateral rectus is connected to the tarsus, if we have to decrease pressure on the globe in case of retrobulbar hemorrhage, not only we have to perform a lateral canthotomy, we also have to perform lateral cantholysis of the respective eyelid to release the crura and mobilize the eyelid. Now, orbital septum is a thin fibrous membrane delineating the anterior boundary of the orbit. It arises from the superior orbital margin, also known as the arcus marginalis. Medially, it is adherent to the anterior lacrimal fascia and then inserts to the medial canthal ligament. Laterally, it inserts to the lateral canthal ligament and to the Whitnell's tubercle. Now, we can see that the orbital septum separates the anterior lid and from the orbit and causes a demarcation so that no structure can pass through except for a few neurovascular bundles. This will be important as any preseptal cellulitis is usually contained within this space. Now, pre-aponeurotic fat pads, they are extensions of the extraconal fat, limited by the anterior septum. Thus, any weak or dehiscent septum, as might be happening in trauma or old age, will cause the fat prolapse, and it is a surgical landmark. The upper lid pre-aponeurotic fat has the central fat pad and the nasal fat pad. Now, the nasal fat pad is from a different neuroectodermal origin and is a yellowish in color and has larger globules. And in the lower eyelid, there are three fat pads, the medial, central, and the lateral fat pads. And here we have to remember that the inferior oblique muscle and its arcuate expansion should not be injured while we are performing any cosmetic procedures to the fat pads. Now, the most important muscle for the eyelid, the levator palpebrae superioris, it originates from the lesser wing of the sphenoid above the annulus of Zinn and superolateral to the optic canal, as we can see in this diagram. It is 4 millimeter in origin, 8 millimeter in the mid-orbit, and gradually fans outwards. It is 36 millimeter in length, divided between aponeurosis and the muscle, 1/3 and 2/3 respectively. Here we can see a diagram of the fan-shaped arrangement of the levator, the muscle, and the termination into the aponeurosis. It also has a conjoint fascial sheath, which is present in the anterior 1/3 of levator, posterior to the Whitnell's ligament. This fascial sheath envelopes the levator, the superior rectus, and also inserts into the fornicial suspensory ligaments. This results in a coordinated movement of the superior rectus, levator, and the superior fornix as a complex. That is, if we look upwards, there is deepening of the fornix. Also, this causes, if there is supramaximal resection of the levator, there might be fornix prolapse. So we have to keep that in mind. Now, the Whitnell's ligament, it is a condensation of the fascial sheath around the levator, seen as a prominent white line. It has two parts, the superior transverse ligament and the posterior layer. The transverse ligament presents as a triangular fashion and the posterior layer as a flat ligament. It functions as a check ligament, that the levator is transverse from the muscle to the aponeurotic part, though this might be controversial. It also might act as a pulley and a pivot to change of the vector of the levator action from the horizontal to the vertical vector. Here we can see the Whitnell's ligament, and this is the levator muscle and the levator aponeurosis, and the Whitnell's ligament is connected to the orbital rim. Now, there are two horns of the levator, the lateral horn and the medial horn. The lateral horn is stronger and it divides the lacrimal gland into the orbital and the palpebral lobe, then slips to the lateral rectus and fuses with the capsulopalpebral fascia of the lower lid and inserts into the lateral tubercle. And the medial horn is weaker and it blends with the orbital septum and inserts to the medial canthal ligament and posterior lacrimal crest. This distributes the forces to the medial and lateral component and causes stability of the upper eyelid and keeps the eyelid opposed to the cornea. And the aponeurosis, it might be single layer in Caucasians or may split into the anterior and posterior in Asians. It inserts 3 to 4 millimeter below the upper edge of the tarsus and also sends slips to the orbicularis and attaches to the skin to form the upper lid crease. Thus, the 5 insertions of the levator at the upper fornix, the medial horn inserts to the medial canthal ligament and lacrimal crest, the lateral horn inserts to the lateral tubercle, the skin inserts to form, the skin insertion causes the eyelid crease, and the tarsus, the insertion to the tarsus forms the upper edge in the upper edge and the anterior surface. Now, when we remove the levator, we can find the Muller's muscle, which is present deep to it. It is a smooth muscle which originates from the undersurface of the levator anterior to the vitals. It interdigitates with the levator and runs downwards posterior to it and inserts at the anterior superior tarsal border. Some have hypothesized that this might be a continuation of the levator muscle itself. There are various theories about its function. That Haramoto's tarsal suspension theory say that Muller's muscle is actually responsible for the suspension of the tarsus and levator is responsible for the skin and the eyelid. And the Horner syndrome is the sympathetic innervation to the Muller's muscle comes from the paravertebral sympathetic chain, and this is hampered in Horner syndrome, and it functions to cause sustained eyelid elevation after levator lifts it. Now, analogous to the levator is the lower lid retractor, which is the capsulopalpebral fascia. It arises from the inferior rectus, the Lockwood's ligament and capsule of the inferior rectus and inferior oblique. Then it fuses with the orbital septum below the tarsus. There is also conjoint insertion to the lower border of the tarsus and slips to the inferior fornix and skin. As we can see in this diagram, the capsulopalpebral fascia, it divides and inserts into the tarsus and the inferior fornix and also gives slips to the skin. Similar to the levator, dehiscent capsulopalpebral fascia causes higher position of the lower lid and shallow inferior fornix, and there might be lower lid retraction in inferior rectus recession. The tarsus is a part of the skeleton of the eyelids. It's a dense fibrous tissue, and it has 20 to 25 meibomian glands in each lid, as we know. And dystichiasis is caused by the regressive metaplasia of the specialized sebaceous gland back to a pilosebaceous unit. I'll not go into the sensory innervation. There are nerves from the lateral to the medial in this diagram, and also the motor innervation. We are running out of time. Now, the vascular supply, you have to keep in mind that in the upper eyelid there is a superior marginal arcade and is a superior peripheral arcade, and these are interconnected between the orbicularis and the tarsus, and this plane should not be disturbed during any upper eyelid surgery, as this will cause torrential bleeding and we have to cauterize all the vessels. But we have to, there is extensive anastomosis between the external carotid system and the internal carotid system in the eyelids, and this causes the excellent wound healing, and also because there is so much good blood supply, that the flaps also have good blood supply, and there is good uptake of the flaps in any surgery of the eyelids. In the venous drainage, we have to remember the angular vein, which is formed by the supraorbital vein and the supratrochlear vein. And here we can see that the angular vein actually lies in front of the anterior lacrimal crest, so that in case of DCR surgery, if we are limited to our actual incision along the orbital rim of the anterior lacrimal crest, we should not actually damage the angular vein. That will cause bleeding. The lymphatics on the outer canthus, the lymph vessels goes to the preauricular lymph nodes, and the inner canthus goes to the submandibular lymph nodes. Now, a little bit about the face scoring. This is the most important tool in the recent times for the facial aesthetic surgeon and the oculoplastic surgeon, as it is a patient reported outcome measure, and it measures 3 domains: the facial appearance, the health related quality of life, and the adverse effects. This is reported by the patients, and each domain includes multiple scales or checklists. This is a framework about how there is qualitative and quantitative research for the FaceQ conceptual framework, and there are a series of items, and a patient is asked to respond on a 4-point scale, and answers are summed up to convert to a score of 0 to 100. For most of the scales, a higher score indicates a better outcome. There is no total score, only scores of the individual functioning scale. Here is the actual phase Q scoring system, and I'll be happy to give the details of the phase Q scoring system, but I'll not go into here. Thank you all. And I hand over the presentation to Dr. Raki Chatterjee, madam.
Good morning, everybody. I thank All India Ophthalmological Society for allowing this instruction course to be presented, and I thank Dr. Salil Mandal, sir, for including me in this team. My topic is eyelid reconstruction, especially the Tenzel's advancement flaps and the double Z plasty. The two things I will cover. Now, the Tenzel advancement flaps are rotational flaps, and these are used to correct the periorbital defects caused by excision of malignant lid tumors, trauma, congenital anomalies, and burn. This is the most commonly used technique in eyelid reconstruction, and in cases of full thickness tissue loss involving 1/3 to 2/3 of the eyelid, we use it. It is a semicircular muscular flap, elevated and rotated to provide sufficient mobilization. Now, while we reconstruct this advancement flap, we have to keep in mind that which eyelid the defect is there. If it is in the lower eyelid, the formation of the flap should be such that it is curved upwards as is shown in the diagram, and it is in the upper eyelid, the mount of the curve should be pointed below. Now, width of the distance between the both extremes of the curve, do you have any pointer? Do you have any pointer? Laser pointer? Pointer. इसमें? Okay. Now the distance between these two ends should be double the distance of the lid defect. Now, while closing the lid defect, after fashioning the flap, we do it in 4 stages. In the step 1, we close it directly. This defect is closed directly, at least with the help of temporary knots. We keep this defect closed. Second one, now as soon as we close this defect, the flap is little mobilized. Then we have to fix it at the canthus with the periosteum. The myocutaneous flap has to be fixed with the canthus. Third one is the conjunctival advancement if required. And fourth one is the excision of the redundant skin laterally and suturing. And with required undermining and all, everything will be done, and it is a customized thing. Now here it is, as I mean, shown that the upper lid, the defect is like this, and the semicircular flap is formed in this fashion. And after closure, the appearance will be like this. Now I'll show a video. It's a malignant eyelid tumor as diagnosed clinically. So we excise it with a 3 mm healthy margin. After achieving the margin clearance, we proceed to reconstruct the lid. And here we have chosen the Tenzel's rotational flap. See how it has been formed. This is the formation of the flap. This is how we are opposing to close the defect. And this is the canthal fixation as a final closure of the excised tissue defect. If required, below also we have to undermine to close it properly without much tension. This is the immediate post-op appearance after 10 days and after 3 months. This is another tumor in the lower lid. The markings are given. This is the marking for the Tenzel's flap. Again, we excise with the healthy margin, and after achieving the margin clearance, preferably under frozen section, we close it. Local cryotherapy is applied. This is the defect thus formed. These are the temporary knots to close it, the canthal fixation, closure of the main wound, and then closure of the tensils, the flap area. Next, I'll come to the double Z plasty. A case of blepharophimosis syndrome is shown here, and it's a surgical challenge. I will concentrate only the medial canthal reconstruction here to correct the telecanthus. Oh, the previous one. No. This one. This is also called as Masters technique. It's a rectangular flap operation. Here, the markings are a little tricky, and this is the principle and the angulation as I have shown. The skin flaps are made. And then the telecanthus is corrected to approximate the medial palpebral ligaments, both the sides. Now, while closing, the technique is such that it forms two Zs, up and down, and it's how does it look. And another video will show a scar revision by doing this double Z plasty. Here the linear incision along the scar to release all the tensions. We have to excise the scar tissues, and these are the markings for the quadrangular flaps we make. We should remember that one point is, first we have to excise all the scar tissue that is causing a pull there. And secondly, we have to, after formation of making the flaps, we have to suture it in such a way, following this double Z plasty technique, the direction of forces are changed, and the pull that was present during the scarred condition is no more there. These quadrangular flaps as shown in the video. The suturing, the apex of the flaps are to be sutured first. And look how it looks at the end. Thanks to everyone.
Hello. Now you see the tangential rotational flap and the all the reconstruction for muscle digit plasty, the clinical application of the geometric flap. Now over to Purvan Ganguly. Purvan Ganguly is the assistant professor of orbit oculoplasty in Medical College, Calcutta. Now he'll talk on cutler beard procedure using trilaminar sclera, because the architectural support is a lots of material is there. Now, but Purvan Ganguly works over the sclera, then we decided the sclera strength is not up to the mark, so you pasted 3 laminar sclera that will be helpful for the architectural support. Over to Purvan.
Thank you, sir. I welcome you all on behalf of RIO Kolkata. Now, the prelude, we all know that cutler beard technique is used for moderate to large size defect of lid reconstruction. It is a bridge flap. It's a lower lid advancement flap where the lower lid flap is advanced and to bridge the gap in the upper eyelid. It's a 2-stage reconstructive procedure. Indications are these. This is a brief steps where you are making an incision, and then the bridge flap is taken over the lower lid bridge, and it is sutured in layers with the upper eyelid defect, conjunctiva with conjunctiva, orbicularis with orbicularis, levator aponeurosis, and skin with skin. Now, in the second stage, we are cutting it out and with a convex lower lid margin. Now, the problems of conventional cutler beard is that it is upper eyelid is actually a shutter due to the presence of the tarsal plate. It's an endoskeleton which makes the lid behaves like a shutter. But in usual cutler beard, after cutler beard, it behaves like a curtain because there is no architectural support in between. So modified cutler beard has come where the advancement flap is split into 2 halves. And in between the 2 halves, tarsal plate replacement is given. Lot of tissues have been used as a replacement of tarsal plate. Nasal septum, tendoachilles, ear cartilage and all that. And donor sclera has also been used. But here we are using a trilaminar donor sclera, which will be thick and which will give better architectural support. The advantage of donor sclera is that it is an offshoot product of the eye bank, and you do not have to do a second site surgery, and the operative time is also reduced. We have rejected donor scleras which have come from septic death due to unknown cause, malignancy, poisoning, and before implanting, 24 hours antibiotic rinse have been done. Now, this is a short video showing how we are preparing the scleral graft. See, this half of another advantage is that the peri-equatorial area of the globe actually mimics the architecture of the upper eyelid. It is convex from outside. So we are taking that part of the peri-equatorial part of the donor sclera, and after removal of the uveal tissue, we are taking 3 such donor scleral grafts. And in order to, how to place the 3 grafts together, and this is antibiotic rinse, and before implanting this graft, so that we do not have to use any suture, we are using donor blood, like the auto blood technique for pterygium surgery. We are taking donor blood and we are putting the donor blood between the 3 scleral grafts so that they stick together and there is no displacement of the donor scleral graft. You can see just before the surgery, and this is the placement of the graft. There is no suture in between the 3 grafts. The graft is sutured with the posterior lamina on its own. Now, this is a surgical video where we'll see the surgical technique of this modified cutler beard. This is a meibomian gland carcinoma, which is coming in the upper eyelid, and we are the incision has been done, and you see the mass is being dissected out. And in some cases of this 13 series, we could do a intra-op frozen section, but not in all cases. So after dissection of the mass, we have to be very careful while dissecting the mass so that there is a 4 millimeter wide margin is there in cases where we could not perform an intra-frozen section. This is an 80% defect, it's a 20 into 20 millimeter mass, and it's a meibomian gland carcinoma. So after the created defect has been measured, we are taking the advancement flap from the lower eyelid, at least 4 millimeter below the lower eyelid, the horizontal incision of the advancement flap must be given. Otherwise, the bridge might slip or it might break. And while taking the advancement flap below the lower eyelid bridge, we use 2O black silk suture, and the suture is passed through below the bridge, and it is taken out through the lower eyelid with the help of a curved mosquito forceps. And you see the bridge has come smoothly. Now it is a very important step where the the anterior lamella and the posterior lamellar dissection is done. Now we have to be very careful while dissecting the two lamella. Both should be equally thick. If the posterior lamella is too thin, then while putting the suture, we might be putting a full thickness suture, and that will irritate the cornea throughout the bridge flap is there, and it will harm the cornea. Now the posterior lamella is being sutured with the upper eyelid posterior lamella, and we have to be very careful not to take a full thickness bite, because if in this step we are taking a full thickness bite, then it will injure the cornea. Now the scleral graft is being placed. We are fixing the scleral graft with the posterior bay that has been formed. And after putting in the scleral graft, it is looking like this. We can refashion the scleral graft as per the requirement and of the created defect. This is the advantage of putting a trilaminar scleral graft. Now the anterior lamella is being sutured with the anterior lamellar part of the created defect, and then we will, this is the first stage, immediate post-op, and this is the day 1 post-op. This is the 1 week, and then we will do a stage 2 procedure after 6 weeks. Now while doing the stage 2 procedure, we have to be very careful, because in conventional cutler beard there is no tarsal replacement. If the convexity of the margin should be downwards, and while putting in this suture of fashioning the gray line, we have to be very careful to put the knot on the skin and not below, because if you are not putting the knot on the skin and below, then it will cause corneal aberration. This is the first month post-op, and we will see another case, another short case video where similar technique have been done. This is also a meibomian gland carcinoma, and this is the marking. Here we could not perform a frozen section. We had to do a 4 millimeter wide resection, and you see the no, in this case we could, the first case we could not. So this is the created defect, and this is the excised gland, and this is also meibomian gland carcinoma. You can see this is a old people. For old people, we have to be very careful because the tissue is very fragile. So there should not be any stretch of the bridge flap. We have to be very careful. If required, we have to modify the flap and take a bit more from down, because if there is a stretching of the tissue, then the tissue will become thinner with further stretching in the 6 weeks, and there might be dehiscence of the flap. So again, posterior lamella is being sutured. We have to keep in mind, and this is, see, the graft is being placed after proper antibiotic rinse for at least 24 to 48 hours. We are keeping the graft inside an antibiotic solution, and then with the autoblad technique, we are, we hope that the graft will be in place. There is no suture in between the 3 lamella. And you can see the graft is being placed on the posterior lamellar bay, and this is the suturing of the anterior lamella which is being performed. And after suturing of the anterior lamella, we will keep the graft for 6 weeks, and so that there is adequate stretching. But we can do it earlier also. Professor Ghosh is trying, he will show his results. This is the immediate post-op. There is a little bit of swelling in this patient in the immediate post-op, but gradually this swelling with time is going away because of the architectural support. This is the stage 2 procedure. Remember, the convexity is being drawn downwards, and this is the immediate post-op. And afterwards, we feel that this small swelling is due to reduced venous drainage in the immediate post-op. This is post-op 1 week. This is post-op. This is a very short video. In similar procedure we are performing. This is a young person, relatively young person, where the tissue stretchability is good. And this is the excised margin, the excised mass. And this is also this is the immediate post-op after the first year. And this is the post-op 6 weeks. This is post-op day 1, and this is post-op after 6 weeks of the stage 2. So this is the immediate post-op after about 2 months. So we have done 13 cases so far, 2 squamous and rest were meibomian gland carcinoma. It is still going on. 6 weeks post-op mean MRD is comparable with the fellow eye, and 6 weeks post-op after stage 2 post-op, the LPS action is also comparable. So far there is no recurrence, and so far there is no extrusion also. My acknowledgements to Professor Salil Kumar Mandal, he had given me the idea of impregnating this trilamellar scleral graft. I'm really indebted to her. And Dichen Bhutia, my JR, for recording and editing the videos. Thank you so much. Now I introduce our chief instructor, Professor Dr. Salil Kumar Mandal, Chief of the Division of Orbit Oculoplasty and Plastic Reconstruction, Regional Institute of Ophthalmology, Kolkata. Sir doesn't need an introduction. He did it MD from AIMS, and after that he is pursuing relentlessly in the field of ocular oncology, plastic reconstruction in RIO Kolkata. He has got numerous peer-reviewed publications in various journals, internationally acclaimed journals. So let us see what we have to see. Over to Professor Mandal.
Hello. Hello. You were just seeing the tumor resection from unacceptable cosmesis to well-accepted cosmesis in the society. So we first start with our experimental surgery over the patient with a clear ethical committee clearance. So no conflicts of interest. So we introduce a silicone plate in replacement of the tarsal plate. Upper eyelid tumor is always challenge to the oculoplasty surgeon. It needs a removal of the large malignant tumor, replacement of the tarsal plate, as well as the reconstruction of the upper eyelid. It's a life-saving, vision-saving restoration of the normal anatomy, achieving stability, motility, functionality, and effective cosmesis. We did a 2-stage cartilage biopsy without replacement of tarsal plate may cause a shrinkage of the entropion, ectropion, and lid shrinkage frequently occur. So first come to our first video. This is a large upper eyelid tumor in the year of 1914. From where I get training from Orbis Flying Eye Hospital. My teacher Chris Fleming doing the auricular cartilage. So I have learned then harvesting cartilage from the back of the ERP splitted again the advanced lid flange into anterior posterior lamina. The posterior lamella fixed with another upper lid posterior lamina to make the posterior lamella bay. So whether this auricular cartilage has been fixed after 6 weeks or 2 months, then we do a second stage of the operation, a lid creation done, and this is the post-operative phase after operation. It's a long duration surgery, second size surgery. Harvesting cartilage from always difficult. Sometimes the break of the cartilage, perforation of the skin, need good surgical assistance. Is there any thought it is possible to do a shorter duration surgery? Is it possible to do a single site surgery? Can artificial tarsal pen can be applicable? Yes, silicone is used in a breast carcinoma. Why not this silicone plate is not being used in the tarsal plate lip? History, composite craft in 1978, TERS is 2001, Achilles tendon Holman 2005, and autogenous silicone 1997. 2018, we first introduced a silicone plate. Silicone plate is not commercially available in the market. It is obtained from 279 retinal buckle. And the configuration is 28 millimeter length, 6 millimeter, 6 millimeter central wide, 30-degree angulation, and multiple hole. Clinical application of this artificial material. This is the first time. The patient having upper eyelid tumor, the procedure was same. We did a 4 millimeter wide upper with a rectangular gap. Rectangular tissue is defect in the upper eyelid. The percentage of defect is calculated by the formula. The upper lid distance is 30 millimeter into created defect 4 millimeter wide upper. That time we have no frozen section availability. 4 millimeter wide upper. We did it and removed the tumor. Less chance of recurrence. Now advancement flap the same manner. A light blue mono. Now advancement flap splitted into anterior and posterior lamella again. This splitting is very important. Either thin, then it will be extruded. Though very careful for the perfect splitting of the lamina. Then the posterior lamella of the advancement flap joined with the posterior lamella of the upper eyelid. Now the silicone plate is replaced the auricular cartilage. Then we think 3.5 hours operation is converted into 1 and a 15 minutes interval. That times we have a lots of tumor patient near RIO. Second stage procedure after 2 to 6 weeks. So it is division done. Then the upper lid creation is done. So this patient, we are doing creation. We have a double nut, the knot outside the skin. So this is the comparison of silicone plate versus auricular cartilage. Mind that aesthetic value in case of silicone plate is much better than the auricular cartilage, that we prove it. Risk of transmission of disease like HIV, hepatitis less. Silicone is an inert non-reacting tissue substance material that's eliminating all the substance of communicable disease. Silicone plate should be considered the material of choice in future generation surgery of lid reconstruction. So again, a challenging case here. This is the patient comes to us, do or die situation, whether I do it or not. This is a big tumor. Very less tissue is there. I have an attempt to save the life of the patients. Tumor is resected. This tumor is anteriorly grow, not enter into the orbit. So we are, our valiant effort, we and our C7 group of doctors, lots of work done for this patient to save the life of this patient. So we did removal of the tumor. There's the highest amount of a created defect. Then advancement flap again. And again this, so we did a splitting. Now again silicone plate we introduce. When the defect is 120%, 100% defect can be repaired by a bridge flap, which most of the medial side of the flap is repaired first. Then the residual gap, which is converted into tangential rotational flap. That is two reconstruction done in a simultaneously. The central medial and central part is by a bridge flap, and the lateral part, the residual gap is defect closed by the rotational flap. That we did it. Now, this is almost converted into bridge flap. The highest defect, more than 130%. Now this is the patient. This is a central part and medial part by the bridge flap, and this is we did an extension of the incision to make a rotational flap. Now this is the patient. Now match that tumor, we remove it. So silicone plate is cost effective, less risk of transmission of the disease, published in Indian Journal of Ophthalmology, and best publication of the year 2021 IJO. Now like a 10 French silicone Foley's catheter introduced as a novel expander device in late reconstruction surgery. Silicone Foley's catheter is not commercially available in the market in a hospital ambulatory setting. 2019, we first introduced the 10 French silicone Foley's catheter. The basis of the tissue expander, the two hypotheses, stress relaxation. Once the force has been used to stretch over the skin, decreasing load is needed to maintain the stretch over time. Creep refers to the increased rate of skin expansion when a constant load is applied over the time. This is the basis of the hypothesis of the expander. Aim to have the efficacy of 10 French silicone Foley catheter is a skin or soft tissue expander to evaluate the cost and safety of using silicone Foley's catheter to assess the anatomical, cosmetic, and functional outcome to assess the safety and efficacy. Comes to the video. Now, this is our first experimental surgery. We don't know what is the result. Now, proposed incision of tangent first done, then ellipse is created, mark it, A into pi into long axis or short axis. Now, single axis dissection done, and the balloon is expanded. Graded balloon expanded for 7 days. On the 8th day, we deflate the balloon. When you deflate the balloon, tissue is relaxed. We recruit an extra tissue. We take the advantage of this relaxation of the tissue, make a rotational flap. Simultaneously, now see the dissection already done by the balloon of the expander device. So you have a less work. Already the tissue is relaxed and you rotate the flap. Now there is fixation of the flap over the zygomatic. This is the patient. There is a question. Why 7 days of tissue extraction? Temporary disfigurement of the face, long hospital stay, and extra expenditure of the patient. Now we change the concept. This is a tumor with a 100% defect. Now we plan for 3 days expansion. On 4th day, we release. Now this is again the ellipse is created at the vertical. This is a color Doppler. We did it. We measure the vascular flow, resistance index, cardiac index, and all the vessel diameter. Now we did expansion of the tissue. Elliptical area, then we did single axis dissection, and the balloon is again expanded. It is for 3 days. Now which coincide with the area of mark ellipse. Clinical application. Now again we do Doppler flowmetry. Now see, the number of vessels are indexed. That it proves that the vascularity flap is increased. We read the hypothesis of the vascularity increase, but it is not proved. Now we, on the color Doppler, we see that the vascularity is increased. After that, we start reconstruction, deflation of the balloon, resection of the tumor, again we do a tangential rotation flap. In this situation, 100% lead defect in the lower lid should be covered by a massage the cheek rotational flap. Massage the cheek rotation, the main disadvantage, you cut the bunch of the facial nerve, which may cause lid lag. Then with the help of expander device, we shorten the incision. And this is a patient. Now see, the length of incision A is the proposed, B is the actual incision, and the flap reduction. This is a schematic diagram. And in this study, the length of incision 70 plus minus standard deviation. This is 110 millimeter of Masadi cheek rotational flap. This is a use, here the beneficiary of the patient in our study. Now, conclusion. The author believes that it makes an excellent tissue expander in underdeveloped world where the access to more expander is limited. The novel utility makes it responsible most prophetic option in the United States and other developed country. So now comes to upper outcome of upper lower lid retraction case for novel filamentous knee. The aim of the study to evaluate the functional and cosmetic outcome of the upper and lower lid retraction by filamentous knitted polyester fabric to appraise the safety and efficacy and durability of the filamentous knitted. Follow the video. Smoking is an art. Follow your hero, but not to follow the art of smoking. Why? The female smoker, much more dangerous. If the patient having a borderline thyroid disease, you have a smoker, you must have developed Graves' orbitopathy. And the earliest feature is lid retraction. The patient these are the sufferer of the lid retraction. How will you evaluate this patient? How will you treat this patient? Is the spacer material applicable? What materials to be used? Is the bank sclera facilitator harvesting problem? What is the ideal material for it? Now, filamentous knitted polyester fabric, the newer material we applied, it is used in thoracic surgery. I use it in the renal scarp in the inactive phase of the disease. We start operating. Lid crease incision made. Tarsal plate is identified. It is detached from the central tarsal plate. Partly resection, partly recession. Disable lengthening of the lid. Now the filamentous knitted polyester fabrics, it is joined to the tarsal plate as a spacer material. So we have a formula that how much the spacer material can be applicable. It is induce a moderate ptosis, that is 5 millimeter, then extra length of amount of scleral show, then extra 3 millimeter. This is the central void of the filamentous knitted polyester fabrics. So in the lower lid, we do a conjunctival approach. In the front of the vest, correct. After conjunctiva, the next structure is the inferior retractor, that is a chief retractor of the lower lid. We dissect from the lower lid and creating a space where the novel filamentous knitted polyester fabric can be used. And conjunctiva is reposited on time. This is a filamentous knitted polyester fabric, conjunctiva partly reposited over the tarsal plate, and the patient kept for 4 days, upper lid traction, and this is the beneficiary of this patient. Wide look, normal look. Again a wide look, again normal look. There's a bilateral process. Wide look, again a normal look. This is our star patients. Everybody knows. We did decompression with the lid reconstruction, we can cover it. So conclusion, as the thickness is 0.06 millimeter, flexible material, lid thickness architectural contour is well maintained, thus FKP is ideal material for it. Now, after that, we think in a way, early division of modified cartilage plate, how it is used. Cartilage beard wait for 6 weeks. Why? The visual rehabilitation is early, should be done, otherwise patient become blind. If it's a one-eye patient, what do you do? Then early division of modified cartilage plate using novel tissue expander for bridge flap, novel filament knitted for the polyester fabric for tarsal plate replacement. So evaluate the surgical outcome of safety of FKF tarsal for 60 to 100% defect to assess the surgical anatomy and cosmetic outcome of early division of modified cartilage within 2 weeks to appraise the cost and effectiveness of the safety of 10 French fillet cutter and FKP in modified clubs. Now see the patient, this is recently done, we did 2 cases. Now this is the upper lid tumor. Again, the expansion area is switched to the lower eyelid. But mind that when you use the lower eyelid expansion, again you do a baseline Doppler flowmetry. Vessel status flow we measured. Now the ellipse is turned, long axis is turned to horizontally to the lid. Now expansion, already tonometry done to reduce. Now on the third, fourth day, we deflate the balloon. What is the object? Tissue is relaxed, more tissue expander, the expander or Doppler flowmetry. So tissue is already vascularized. Now we take the advantage of the vascularity of the tissue as well as the stretchability of the tissue and extra tissue. That will help to negotiate from lower lid to upper lid and early division help, because already extra tissue. We applied this new concept here. This is a filamentous knitted polyester fabric. As a tarsal plate design, we replace over the tarsal plate, over the posterior lamina bay. Now it is anterior lamella is repeats. Cutler beard done on 15 days. Now see the tissue is almost up, looks like a 6 week. Now again the convexity downwards. We cut the bridge flap, and the patient is almost visually rehabilitated within the 2 weeks. Cutler beard procedure wait for 6 weeks at least. Now we apply the new device, the new technique that we can rehabilitate the patient within 2 weeks. That is the advantage of this technique, conjunctival deposited. This is the postoperative phase. This is a preoperative phase, a postoperative phase, closure and opening. Just 1 month is over. If it is 6 months, lid is almost normal. Last video. You know the situation we crossed, COVID-19 attack and sudden surge of mucormycosis. We are really puzzled which operation is the ideal. 30th May 2021, I am the nodal officer of Medical College, Calcutta of a COVID situation with mucormycosis. I don't know anything about the mucormycosis, and I know orbital excentralization, but in mucormycosis, how to save the life. Is orbital excentralization done? This is an extensive damage of the patient of an eye. 7 surgeons are to save the life of the patient. This is a challenge for us. Necrosis of the medial wall, inferior wall done, we debride again. Feeding jejunus to be done because the 2 months have a parental literacy. Is there any alternative surgical process? Is early diagnosis helpful? Is a last pairing orbital is effective? The last pairing orbital excentralization is not written anywhere. That time you do, yes, last pairing, we can do it. Here, the last is preserved. In orbital extension, last is never preserved. Never written in the book. But in the mucormycosis, we learn this is not a tumor. This is an infective state. We can preserve the last. The pathology in the orbital apex. When you control the pathology in the orbital apex, it cannot be extended to the brain. So, canthotomy incision close. Now, this is the patient of we give a deoxychelate amphotericin B injection routinely, and also scrapping the. This is deoxychelate liposomal amphotericin B. Another thing you observe it when it is a closed eyelid. You know the movement of the eyelid. Always in the sinus, they get negative pressure, positive pressure. When you inspiration, this is fine. Now, this is the first patient. Medial wall gone, floor gone. How can the patient eat oral food? Now, we applied a palatine prosthesis. This is the palatine prosthesis. Now, oral fluid is added. The patient in insulin-dependent diabetes now present is orbitally extended. The patient sees, I have a legal right to survive in this beautiful world. Thank you. Arekta video ache. As a Shahid Alam is one of the presenter in our session, but he's not there. I have to present. Where's the video? Here? Yeah. I can. Yeah, video. It's only video. This is the. Hello. 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 Now this is a maggot infestation of the lid. Severe maggot infestation of the lid. Maggot is removed either from ether or tarpental oil. As the presenter is not here, that I have to cover this topic. Old age, family ignorance, negligence leads to more advanced stage of lid cancer with severe maggot infestation. First, dressing of the eyelid is very essential to make the lid, to make the tumor healthy, debride all the infected tissues. The patient feels alone, helpless, and move towards death. This is a live maggot. No problem. Our resident was working very hard for this patient. Now we start reconstruction. The patient wound is healthy from Regional Institute of Ophthalmology, Calcutta. Large upper eyelid tumor. Resect the tumor with a 4 mm wide margin with a rectangular gap. The tumor is well excised with a frozen section biopsy. This is a bridge flap, we made it. Now harvesting auricular cartilage from back of the ear pinna. All the ear is not same. Some of the cartilage are break, some of the cartilage are healthy. And all the curvature of the cartilage is not same. The curvature of the eyelid contour is 30-degree angulation, which is not available in the auricular cartilage. But we have to do an architectural support. Lower lid advancement flap slitted into anterior posterior lamella. Here the splitting is very important. Posterior lamella should not be thinned out, otherwise it will be exuded out. Then the posterior lamina from the advancement flap is also taken. Here the auricular cartilage is fixed over the posterior lamina bay. Fixation of the polygalactic suture 50. And the anterior lamella is closed. After 6 weeks, again we convex it downwards incision. Eyelid is open. And the lid margin suture is secured. Should not be any knot exposure to the cornea other than may cause exposure keratitis. And the wound is closed. Now see the patient. The patient is thrown from the family due to infection. This is the post-operative phase of the patient. This smile is my gift, nothing but. Over. Yeah.
And our people is really great because we get more complicated and difficult cases.
Indian surgeons are very expert in tumor situation, you know. In American never says the tumor, what tumors there are. I have lots of tumor here. But there are no patients are there. Oh. Over, next session. Okay. Yes. Mic. Which case?
It's a mic.
I have a lots of architectural support. Silicon plate, molecular cartilage, FKPF, the new generation metal, filamental knitted polyester fabric. No complication. Patient is excellent.